and glutamate results in polymerization, which is responsible for the abnormal red blood cell shape. B saying sickle cell trait have shown resistant invasion by malaria parasite. C, the B prime gene is found in high frequency in many parts of Africa. D, as many as 20% of patients with sickle cell anemia exhibit sequelae of cerebral vascular accident. E, dactylitis is more common in infancy. Any thought on this question? Anyone wants to give it a try? Anyone? Let's feel free. Mm, Any thought that we have, we can get to give them and then we get to discuss. Okay. Our good doc says A. Why do you choose A? Okay. All right. Thank you so much. Is there any other thought? Or we are good with that one? Okay. Thank you so much, my good doc. Is there any other thought? Okay. So now let's just add together what our good doctors have said. Uh, for A saying they switch in the amino acid valine and glutamate. So we have got amino acid glutamate is also known as glutamic acid. It is different if they had said glutamine. This one is different. But glutamate is glutamic acid, and we know that what is going to be happening in sickle cell. First thing first, sickle cell disease is a recessive disorder. It's autosomal, it's not sex linked. It's an autosomal recessive disorder where at the sixth position, there's going to be substitution of uh, valine for glutamate. In other words, where there was a valine, that's why I put glutamate or glutamic acid. So there is that mutation. And this is specifically on the sixth position of the beta gene. Okay. So we have got sickle cell anemia and sickle cell trait. Anyone who can help us to differentiate the two? What's the difference between sickle cell anemia and sickle cell trait? So, sickle cell anemia is just an homozygous state where you carry two sickle genes from both parents. So it is HBSS. Sickle cell trait is you have got one gene that's normal, which is adult hemoglobin, and then the other one is going to be abnormal. So it's HBAS. Okay, so that's what happens. Now the problem, what happens is that in sickle cell anemia, you have got these so-called red blood cells. But what causes the problem is there is a precipitating factor. Some of the precipitating factors includes things like hypoxia, dehydration. So in such conditions, what is going to happen is that the hemoglobin S cannot withstand those conditions. Okay, like when there is hypoxia. So therefore, if exposed to low levels of oxygen, the HBS will start to polymerize. They start clamping to each other. And as they do that, they are going to become distorted, and then that will lead now to the sickling, because as they get to be distorted and clamped together, they are going to be blocking blood vessels. So that is uh, what even leads to the different clinical features like the vaso-occlusive crisis that we see. Now, the features of anemia and the features of chronic hemolysis in sickle cell disease, you start seeing them after 6 months of age. That's why it's very tricky to diagnose sickle cell anemia in someone that is less than 6. Uh, Now, the features will start at 6 months, not 6 weeks. That's why it is a bit tricky to diagnose someone with anemia that is less than 6 months. So option A is correct. Option B is saying sickle cell trait have shown resistant invasion of malaria parasite. And this is true. That's why majority of the people that have got sickle cell is from our region, like the African descent, because this is where we have got malaria, and it's a form of protection. So people that have got a trait, they are protected from the parasite. The beta prime gene is found in high frequency in many parts of Africa. Now, if it is the beta gene, yes, it's supposed to be found in high frequency because this is actually the same thing that is protective from the malaria in Africa. All right. So if it was supposed to be the beta S gene, would have been correct. But what they have given here is not the one that is defective. The beta prime gene is not the one that is associated with the sickle cell disease. Instead, the gene that we are interested in this case, that they might be talking about, is the one that codes for the beta globin chain of hemoglobin that is found on chromosome number 11. This beta prime gene is found on chromosome number 14, and it codes for the hemoglobin chain HbA2. But this A2 is actually not the one found in a majority of the people. This one is found only in a minor uh, or few people, or few forms of hemoglobin in the adult. So it's not the one that is associated with the sickle cell. D is saying as many as 20% with sickle cell exhibit sequelae of CVA or stroke, and that's true. And dactylitis, which is the hand-foot syndrome, is common in infants. That's also true. Right. Number 12 is saying how many liters of packed cells does a 12 kg child with hemoglobin of uh, 5 grams per deciliter need to raise the hemoglobin to 8 grams per deciliter? Now for this one, if we are to answer it, we need to know how to calculate, because there's actually a formula. And the way we calculate the formula for the amount of packed cells needed to raise the hemoglobin level, so is given by desired hemoglobin level minus the current hemoglobin level times 4 times the total body weight. Okay. So so for this question we've been told with hemoglobin of 5 to raise it to 8. So we'll say 8, that is what we desire, minus 5. Okay. And then we multiply by the body weight. In this case, this is 12. And then multiply by 4, which is a constant. 8 minus 5, that's a 3. 3 by 4, that's a 12. 12 by 12, that's 144. So that will give us 144 mils. That is going to be the number of milliliters of the packed cells that are going to raise this hemoglobin. 13 is saying the following features associated with Hodgkin's disease: pale Epstein fever. The liver is the most frequent involved site in children. Staging, laparotomy, and splenectomy have a role in management. Radiation therapy alone cannot be used to treat the tumor. Patients normally present with painful nodules. Anyone that can help us with this question? For the previous question, it's 144, question 12. Yes. So we have got this one here. Any thought? What would be the answer? Anyone that can help? We want a feature associated with Hodgkin's disease. Anyone? All right. So maybe the first thing we need to understand is what is Hodgkin's disease. Anyone with just anything to say about it? The Hodgkin's disease? Feel free in case you have got something to say so that the discussion will become even more interesting. Yeah. Mm. Thank you so much. It's a cancer, right? It's also known as Hodgkin's lymphoma. It's a cancer originating from the white cells, which are the lymphocytes. And the characteristic feature about the Hodgkin's lymphoma are the cells, the multinucleated B cells, which are known as the Reed Steinberg cells. And where do these lymphomas come from? The Hodgkin's lymphomas, they arise from the lymph nodes, especially the lymph nodes that are present in the cervical and the mediastinum. And when you look at the features, the clinical features of Hodgkin's lymphoma, there's going to be lymphadenopathy, which is the commonest presentation, and this is painless. And then someone is also going to have B symptoms, for example, fever, and that is known as that's the referred to as the Pale Epstein type. Okay, and then there will be the night sweats and weight loss. Another feature that can be seen is alcohol-induced lymph node pain. Like when someone is taking alcohol, there is pain in the lymph nodes, though it's rare. And then another thing will be pruritus, and there's also going to be fatigue and hepatosplenomegaly. Okay. The way you're going to diagnose Hodgkin's lymphoma is you can do an excision lymph node biopsy so that you can be able to see the Reed Steinberg cells. You can also do imaging, for example, the PET-CT, if you want to help in staging the cancer. And you can stage the cancer using the Ann Arbor system from 1 up to 4. And as you stage these ones, you also have the subclasses. For the treatment, you want to do chemotherapy with sometimes you can add radiotherapy. So that is a basic overview about uh, this cancer. So when you look at our option, therefore, we want to what is associated with Hodgkin's disease. So the pure Epstein fever is true, right? What we describe as the pin Hodgkin's fe- uh, the pill Epstein fever is a cyclic fever. It is going to rise and fall over days to weeks. It's cyclic, like it repeats. Yeah. So that is the best option that we can pick. B saying the liver is the most frequently involved in children. Really not true. We've just from mentioning that what is mostly involved are the lymph nodes. Staging, laparotomy, and splenectomy have a role in management. This really is not true. Of course, staging is going to be important in the way you get to treat the condition, but this one is specifically staging laparotomy, which I don't think is really true for this one. So, while staging itself is important, the surgical procedure is not just going to be done because this laparotomy is surgery. You not just do the surgery just to come and stage the condition. Because for the staging, we actually use an excision biopsy. All right. And then D is saying radiation therapy alone cannot be used to treat the tumor. Now, re- this statement is not true. You can use the radiation, okay, or you can use the chemo or a combination. Patients normally present with painful lymph nodes. We are just from saying that these lymph nodes are actually painless. So the best option is number A. Is this okay? Thank you. 14 is saying, sorry? Oh, the alcohol induced pain in the lymph nodes. Yeah, if someone is taking alcohol, they start having this pain in the lymph nodes, alcohol induced lymph node pain. Number 14 is saying, which of these is not applicable in non-Hodgkin's lymphoma in children? The endemic type, Burkitt's lymphoma, is associated with EBV infection in more than 90% of cases. Can be a cause of interception in children. Regardless of stage, all patients should be treated with intrathecal chemotherapy. And then D is saying the level of serum LDH as a prognostic sign. And then E is saying CSF examination is not part of the initial assessment. Any thought on this one? Okay. Why do you go for that one, Doc? Why do you go for C? Okay. All right. Is there any other thought from anyone? Okay. So on the previous question, we are mentioning the about what? About the non-Hodgkin's lymphoma, the Hodgkin's lymphoma, which commonest presentation is the lymph node, the lymphadenopathy that is painless. For the non-Hodgkin's lymphoma, this one also can arise from either the B cells or the T cells. Remember, I said that for the Hodgkin's, it's coming from the B cells forming these It's actually a tumor that arises from the lymph nodes, most affecting the B cells, forming those red Steinbeck cells. In the non-Hodgkin's lymphoma, it's going to arise from either the B cells or the T cells, and it has got subtypes. There is the Burkitt lymphoma, which is associated with Epstein-Barr virus. There is a diffuse large B cell lymphoma, the lymphoblastic lymphoma. Lymphoblastic normally comes from the T cells, and then anaplastic large cell lymphoma. So when you look at the clinical features for this one, you are going to have a mass that is rapidly growing. It can either be in the abdomen, in the mediastinum, or the head and neck. Those are non-Hodgkin's. And then there also be the abdominal non-Hodgkin's lymphoma, which is actually the buckets, which may present with intussusception, like you are going to have the part of this bowel going into the other bowel. And then there can be bowel obstruction, there can be ascites, and there can be palpable masses. Okay, that's the abdominal non-Hodgkin's. Intussusception, intestinal obstruction, ascites, or palpable mass. In the mediastinum, and remember the abdominal one, the commonest is going to be the bucket, which will cause all those problems. In the mediastinum, often it's the going to be the T cells, okay, the lymphoblastic lymphoma. This one is going to result into respiratory distress, superior vena cava syndrome. And of course, in non-Hodgkin's, you also have B symptoms: fever, weight loss, night sweats. Sometimes the CNS can be involved, where someone is going to have headache, cranial nerve palsies, and altered mental status. So when you want to diagnose this patient, again, you can take a biopsy of the mass or the lymph node. You can do the CSF exam, which is mandatory, so that you see if there is any CNS involvement. You can as well do a bone marrow aspirate or biopsy, and then you can also get to do imaging, for example, CT, MRI, and such. So for the treatment of these cancers, you can use the chemotherapy, systemic chemotherapy. You can also do intrathecal chemotherapy. Now, intrathecal chemotherapy is given to all patients for CNS prophylaxis, and it doesn't matter which stage you are talking about. And then for the radiation therapy is also able to be used, but then rare. For radiation, it is normally reserved for those cancers that are bulky or that are refractory in nature. Yeah. So that is on the non-Hodgkin's lymphoma. So when we look at the options that we have, A is saying the endemic type Burkitt's lymphoma is associated with ABV, and this is true. B is saying can cause intussusception in children, which is true. C is saying regardless of stage, all patients should be treated with intrathecal chemotherapy. Now, intrathecal chemotherapy is not for treatment, it's chemoprophylaxis, it's for prophylaxis. And then D is saying the level of serum LDH as prognostic signs. That's true. Actually, for prognosis of these cancers, what determines if there's going to be poor prognosis or good prognosis is the stage at the point of diagnosis. Okay, is it stage 1, 2, 3, or 4? Number 2 are the levels of LDH. Number 3 is the CNS and bone marrow involvement. Number 4 is the response to the initial therapy that you provide. These are the things that determine the prognosis. So this is true. And then E is saying CSF exam is not part of the initial assessment. CSF exam is actually part of the initial assessment. Very important, because you want to make sure you rule out CNS involvement. Okay, so the answer in this case is going to be C. 15 is saying which of the following statements is most correct concerning seizure disorders in childhood? Febrile convulsions are the most common seizure disorder during childhood. The duration and state of consciousness are not important in childhood seizures. Absent seizures are more common in boys than girls. Any child with a prolonged seizure should be treated with anticonvulsants for life. A child with seizure disorder should be seizure free at least for 3 years before anticonvulsant drugs can be weaned off. So, for this one, any thought, which one do we think is the most correct statement? Anyone? Yes, yes, doc, please. Okay. This one? Sorry? Okay. CSF exam is not part. Oh, this one is actually saying is not part of the initial assessment and is supposed to be part. So this question is asking of which of the following is not applicable in non-Hodgkin's lymphoma in children. So option E is saying CSF exam is not part of the initial assessment for the patient. Maybe I'm not understanding it. Can someone explain what's happening on the options? CSF exam is supposed to be part of the initial assessment. So when it comes to the not applicable, is it applicable or not applicable? Maybe it's the English or the question. Yeah, so in this case, the best answer we can even end up with is E because of the not applicable. So C is saying regardless of stage, all patients should be treated with intrathecal chemotherapy. Maybe they are meaning that same treatment is the prophylaxis. But E is definitely not true because CSF exam is part of the initial assessment. This intrathecal chemo, we are giving it regardless of the stage for prophylaxis. And prophylaxis is also can be part of the treatment. Yeah. So this one, we can classify it at least in some way, option C. But option E definitely can't be qualified because you want to make sure that you rule out CNS involvement in these patients before the CNS is involved, which is going to be very bad. Yeah. Uh, mm. Hope that's proper. Okay. Mm. So which of these is most correct concerning seizure disorders in childhood? So what can we pick here? Anyone with a thought on that one? Okay. Option A. All right. Thank you so much. When we look at children, well, something before we can even just talk of children alone, We know seizures, we've been discussing this nearly every time we're talking about PEDS and these other courses. Seizures can be partial or generalized. Specifically, the partial seizures, you can have those seizures that are partial and then they have got uh, awareness, and then there's impaired awareness. Okay, so you have got focal aware and focal impaired awareness. And then you have got the generalized seizures, which you can split into tonic, clonic, and such things. The febrile seizures, these ones, something special about them is that it should happen in children who are between 6 months. So we say 6 to 6, right? 6 months to 6 years, but some other books use 5 years, 6 months to 5 years. And the temperature should be greater than 38 degrees. There should be no any other explanation for that seizure, right? So that is a febrile seizure. And these seizures can be simple or they can be complex. So simple ones are generalized, like they affect the whole body. And then the yeah. So the febrile seizures, the first thing is that they happen in children between 6 months and 6 years. Other books will say 6 months to 5 years. For you to say this is a febrile seizure, they should be triggered by fever. This should be a child that has got a high temperature, the temperature greater than 35 degrees. And there should be no other explanation for these seizures, because in that case, we'll not be able to say that it's a febrile seizure. Now, besides that, these febrile seizures, you can classify them. You can classify them into simple or complex seizures. Those ones that we refer to as a simple seizures, they're actually generalized. They affect the entire body. And the simple seizures are actually going to be brief, okay? Like they occur less than 15 minutes. Now, the complex seizures are going to be focal. They affect one part of the body. And for these ones which are complex, they are going to actually be prolonged greater than 15 minutes. So that is about the, at least what we should know about the febrile seizures. Yeah. So please don't forget about the features. 6 months to 60 months or 6 months to 6 years. Some will say 5 years. And then it should be within 8 to 12 hours since the fever started. There should be no evidence whatsoever of another CNS infection like meningitis or metabolic disease. There should be evidence of extra cranial infection. There should be evidence that this person has got an infection that is not an infection of the cranium, not an infection of the head. For example, otitis media, tonsillitis, that can be the one where the fever came from to cause this febrile seizure. And it should occur in the absence of history of prior febrile seizure. So if someone had an febrile seizure, you see that happened when the temperature was normal, and then they have got this one now, you not say it is a febrile seizure. Okay, so those are the features that you get to look at. So therefore, looking at our options, febrile convulsions, that the most common seizure disorder in childhood. That statement is actually true. They are very common. They are the most common because these children are actually more likely to have infections that is going to make them to have these seizures. B saying the duration and state of consciousness are not important. This is important. Absence seizure are more common in boys than in girls. That statement is not correct. Absence seizures can happen more, they're actually more common in girls than in boys. And then any child with prolonged seizure should be treated with anticonvulsant for life. That statement is not correct. Okay. It's not every child that has got a prolonged seizure that should be treated with anticonvulsant for life. The treatment decision actually depend on the what is the cause. Is this seizure likely to come back? And when you look at the EEG, what are the findings? So let's say, for example, if you just have one single seizure that is prolonged, it will not mean that you give this child treatment for life. It can just be a febrile status epilepticus. And then he is saying a child with seizure disorder should be seizure free for at least 3 years before anticonvulsant drug can be weaned off. That statement is really not correct. Yeah. So there are many things that will look that you are going to consider for you to be able to wean someone off these seizure drugs. Some of it, of course, you have got a period, but you also have the type of the seizure, the finding on the EEG, and also the cause. You consider all those for you to be able to wean a patient from the anti-seizure drugs. Yes. I hope that is okay. Number 16. Which of the following investigations should be done in a 3-year-old boy suspected of suffering from mild intermittent asthma? Chest X-ray,
Hello.
peak. Oh, yes, doc.
I didn't get like the reason why this cerebral seizure is the most common in this age group. Then if I didn't get your statement,
Oh,
you're talking about these people like being affected by infections, and according to the definition of the cerebral seizures, you said there should be no like evidence of like what could account for the seizure in the patient for it to be considered as a cerebral seizure. I don't know. I need like a clarity on that.
okay. Thank you. So for the febrile seizures, there should be no prior history of an infection from the CNS, no evidence of CNS infection like meningitis, and also no metabolic disorders. But there should be extra cranial infections. So there should be evidence of extracranial infections like tonsillitis, otitis media. So if someone has got meningitis and then they are having a seizure, you can't call it a febrile seizure because that's the broken one of the diagnostic criteria. So the febrile seizures are the most common type of seizure in children between 6 and 5 years. And often they're going to be triggered by fever without underlying CNS infections, maybe an infection because of the otitis media from these staph infections, strep infections, or tonsillitis. Yeah, so that is what causes it.
Okay. So before we go to the next question, okay,
Mhm.
let's say for example, like these patients that have uh, malaria due to Plasmodium falciparum, like the infection is not really like in the CNS, but it ends up like complicating to the CNS and cause these convulsions. So do we consider such as like a cause of a febrile, or maybe as long as the infection like involves the CNS and causing the seizure, it's no longer like it cannot be considered as a febrile seizure.
Okay, now, nice question. Any thought from anyone?
From my understanding, you said that's a type of seizures that can be categorized as a temperature of a fever greater than 80 degrees Celsius and common in age group of children aged above 6 or 5 years. And they present without Meningitis infection, non-metabolic stenosis, or history of Parkinson's disease. Yes. So, no any infection. A lot of people that people care about because of infection caused febrile seizure or disqualified to be. How, because it's looking for some a seizure or something of disqualified to be a febrile seizure or disqualified to be a febrile seizure. Yeah, something like
Yeah. So I support what the doctor said. We are going to disqualify it. If you have got an infection that ends up like, for example, say malaria, we know the if yesterday we had said we look at the complications of severe malaria. Hope we did look at that. So let's say we have got any condition that results into a brain disorder, maybe leading to the CNS complications. We are going to put that as a CNS infection, right? So we are going to disqualify that. So someone should have a high temperature, but not a CNS infection. Whatsoever that is causing that CNS infection, wherever it came from, will not matter as long as it's a CNS infection. So will not qualify it. But if someone has got an infection, for example, otitis media, this is confined to this area, and then someone has got an elevated temperature in 12 within 12 hours or 12 to 16 hours. So in this case, they get to develop, because we also have a period that is linked within 8 to 12 hours. They get to have these seizures. Then we are going to put them to fall under febrile seizures. But if there is any history of these CNS infection whatsoever they cause, then it ends up being disqualified. Okay.
oh, sorry, doctor.
Yes, doc. Hope we are good.
Oh, are you getting?
Yes, yes.
Yeah, focus. I think what you have to keep in mind is that these seizures, which are fibrous orientated, they are not the same. We don't have to consider them as the same as epilepsy.
Hmm.
Yeah, it's just like the age-dependent response to fever because of the immature brain.
Yeah. Thank you so much. Yeah, it's another category of seizure on itself. So it shouldn't be considered as part of this epilepsy. Okay. So 16 is saying which of the following investigations should be done in a 3-year-old boy suspected of suffering from mild intermittent asthma. Chest X-ray, peak expiratory flow rate or flow, spirometry, skin prick test, and none of the above. Any thought on this one? Which one can we do for a 3-year-old who is been suspected from from having mild intermittent asthma?
Um, I think
Sorry?
but I'm not sure.
Okay, D. All right. Is there any other thought
I'll go for it.
for E? Okay. Okay, why do you go for E?
Or I'll go for it.
Hmm.
Okay. So starting with the option A, basically, not to primary diagnostic for ruling out asthma. I think pyrethroid flow it's also not reliable in younger children.
Okay.
Yeah.
Anything more? Oh, that's it.
So also for C, I don't know, but for D, what I know is that it's used it, it is used to identify the triggers for asthma, not for diagnosis.
Okay. Thank you so much. Yeah, so just to add, as the doc has said, when you look at the spirometry and peak expiratory flow rate, the way you get to do this is they actually the gold standard when you want to diagnose asthma. But the patient should be someone that can at least listen to the instruction you are giving them. For example, you are going to ask them to take in a deep breath and then blow the air into this spirometer or the peak expiratory flow meter. Now, a 3-year-old might not be able to follow those instructions. So, for these ones, you want to ask the patient from 5 years to 6 years. That's when you can use the spirometry and the peak expiratory flow, because at that point, at least they can listen to what you are going to tell them. Chest X-ray is not really for diagnosis of asthma. So it's going to be used to rule out other conditions that can cause these difficulties in breathing, not really asthma itself. Okay. Because if you do an X-ray, you might find that it's normal, but then someone has got this asthma. So it might be unnecessary. For the skin prick, this one you just use to identify a specific allergen that is triggering the asthma symptoms, right? So they are not really there to diagnose the condition. So if you find that it's positive, what does it mean in that case? It might not mean really that the patient has got asthma, okay? It might just mean because a positive skin prick is actually just an allergic sensitivity. So it does not confirm a diagnosis of asthma without a supportive clinical evidence. Maybe this patient was vaccinated, they end up showing a positive skin prick. So it's not really for diagnosis. There should be also some supporting clinical evidence. So it's none of the above. Features of life-threatening asthma in a 11-year-old girl include all the following except ability to drink but not feed, respiratory rate greater than 50, pulse rate greater than 140, altered level of consciousness. So which one of these is not a feature of life-threatening asthma?
I think I have to go for it.
All right. Why do you go for a doc? Any thought why? Why A? Okay. When you look at what we have here, an ability to drink but not to feed, and then you have got respiratory rate greater than 150, and then altered mental status. So, firstly, what is the problem in this case? If this is asthma, right, and it's life threatening, so there is obstruction to the airways, someone is not able to take in enough air. So for the option A, a bit to drink but not feed. If someone is able to drink, it means actually it might not be that bad. Although, because for this life-threatening asthma, if they are not able to talk or feed, that is a sign of the severe form. So feeding of any form, including also the drinking, right? So a child who is, let's for example, like in the severe form of asthma, the child will become even breathless. And someone who is breathless will not be able to talk, will not be able to feed. Okay. So the ability to drink or feed would be a positive sign. That means that the condition is less severe. It's not life threatening. When you look at B, respiratory rate greater than 50. So the respiratory rate has increased in this case. It is high because there's going to be respiratory distress. Remember, there's obstruction in these patients. So they are really not taking in air. So because of this respiratory distress, the respiratory rate increases. This is the body's attempt to try to bring in more air. And then the pulse rate greater than 140. Again, this one also is is showing that there is actually tachycardia because the heart is also trying to compensate because of the little oxygen that is going in. A silent chest might be there. This means that there's actually some serious, maybe impending respiratory collapse, or maybe there is no longer enough airflow to produce these movements in the chest or the wheezing sounds. So a silent chest might just mean air is not going in. Altered level of consciousness can also be a feature. For example, someone might become drowsy, confused. Those are signs of hypoxia because in this case, in asthma, there is obstruction to airflow into the lungs. Right? Number 18 is saying the following drugs may be indicated in the management of acute rheumatic fever except lorazepam, aspirin, haloperidol, diazepam, ciprofloxacin. Anyone who can help us with this one?
The answer for this previous question is A.
Sorry?
The answer for question 17 is A.
Yes, for question 17, the answer is A. So, number 18, which one of these drugs is not going to be used in the treatment of acute rheumatic fever? Any thought? Acute rheumatic fever. But we know what rheumatic fever is, right? Someone, and we know it's common between, what's that? Between 5 to 15 years, someone has got, yes, yes, doc? Oh, it's not showing that it has moved. It has moved on my end, but I've seen it's not just moved here. Okay, let me just try to do this. Hope we can now see. So I was saying that in rheumatic fever, it's common between the age of 5 to the age of 15, where someone has got uh, is an infection by staph, the group A beta hemolytic, not staph but strep. Yeah, between 5 and 15 years. Normally, they have got what we call scarlet fever, and then about 10 years later, a decade later, or some few years, they are now going to start developing these symptoms of affecting the heart. That will be going to the rheumatic heart disease, right? Showing the symptoms on the heart. When we are diagnosing rheumatic fever, there is a major criteria and the minor criteria. The major criteria, that's why you look at the mnemonic space, where I've got the Sidenhen's Korea, I've got a pancreatitis, you have got uh, the S subcutaneous. Which one is that? The subcutaneous. I hope it's the one subcutaneous nodules, and then which one have I left out? And then you have got a erythema marginatum, SPACE, and then you have got the minor criteria, where you are going to look at the C-reactive proteins, the ESR. Okay. So on the drugs that you use for acute rheumatic fever, number one of the drugs that have been mentioned here, lorazepam, which is A, and diazepam. These two drugs are both benzodiazepines. They can be used, they can act as sedatives, because, as we've said, one complication can be Sidenhen's chorea. So, as sedatives, you can use them for this neurological problem. Aspirin, we know aspirin is an NSAID, so it can actually be used to treat the. So the A in the space, the mnemonic space, the A is arthritis, specifically polyarthritis, because it involves many joints. So the aspirin can be used to treat the arthritis and also the carditis, basically inflammation, because it's an anti-inflammatory drug. Haloperidol is an antipsychotic drug, so it can control also the severe movements that are happening in Sydenham's Korea. The other option here they've given us is Cipro, which is a fluoroquinolone. Now, this one is not the drug that you want to use for the group A, beta hemolytic infections. In strep infections, the drug of choice is actually penicillin, not a fluoroquinolone. We can as well use, in case of allergy to penicillins, you can also use things like azithromycin and cephalosporins. So Cipro is not used really. Number 19 is saying, so uh, ciprofloxacin, that's E. It's going to be the exception. Which of the following drugs is most unlikely to be useful in severe dilated cardiomyopathy? Now, again, we know that in cardiomyopathy, we have got three main types of cardiomyopathy. We have what we call dilated cardiomyopathy, hypertrophic cardiomyopathy, and what we call restrictive cardiomyopathy. For hypertrophic cardiomyopathy, this is where the heart is really hypertrophying, the heart muscle is hypertrophying. Hypertrophy and dilatation is different, because for hypertrophy, you are actually looking at the walls of the heart. Those are the ones that are becoming thick, and that will mean that blood that is coming in the heart is going to be little. For dilated cardiomyopathy, you will see that the ventricles are becoming very, very big. Okay. For a question about hypertrophic cardiomyopathy, this is very common in young active people. Maybe someone is playing football, they just end up falling down, they die and then there's no clinical evidence really what would have caused that. But when you look at the heart, that's when you'll be able to see that there's actually a problem. The heart got dilated. Okay, so that is it. It got hypertrophied. So in the management of this cardiomyopathy, basically with the others, you want to look at the complications. So here the drugs we have got furosemide, spironolactone, captopril, and the digoxin. So in the management, because in dilated cardiomyopathy, just like any other, it can result into heart failure. And we know that in heart failure, there can be fluid overload that leads to the edema. So what should you do? Give a drug that is going to reduce the fluid, for example, furosemide, which is a loop diuretic. And then spironolactone can also as well be given. This one is an aldosterone antagonist. Captopril is an RC inhibitor. Angiotensin converting enzyme is also a diuretic. Digoxin is a cardiac glycoside. It's going to block the sodium potassium ATPase pump, and it also gets to reduce the symptoms of heart failure. For example, the atrial fibrillation. So the drug that remains here is aspirin. Aspirin is a drug that is used in inflammation, in pain, but besides that, it can also inhibit the platelets to stop clots. So because it inhibits platelets, you can use it for conditions like in ischemic heart disease, where there is no blood supply to the heart, maybe because of a clot formation, and also in stroke, not in cardiomyopathy. Okay, so that one is going to be the exception. And then question number 20. The following are common causes of hypovolemic shock in children except hemorrhage, gastroenteritis, septicemia, burns, spinal cord injury. What do we think about this one? Which one is not a common cause of hypovolemia in children?
No.
Sorry? Which one have you picked, Doc?
Fine.
Oh, C, septicemia. Okay. Is there anyone that has a different thought? Any different thought?
Mm.
Or we all go for C? Why do we pick C, Doc?
I was just guessing though, but thinking like maybe for this one it would cause like septic shock, not hypovolemic shock.
Yeah, I think that's a good one. Septic shock, which is a type of distributive shock instead of hypovolemic shock. For spinal injury, also, in that case, we can think of it because spinal injury is going to result in neurologic shock. which is again a type of distributive shock, which falls in the same category as septic shock, which is also a type of distributive shock. So why would we pick septic shock over, I mean sepsis, septicemia over spine injury? Any thought?
Oh, this is too quick. September.
Okay. Any why? Okay. We can go with sepsis, isn't it? Sepsis is a type of distributive shock, and what happens in distributive shock is that these bacterias, of course, the bacteria, neurologic shock is also another type of distributive, but specifically here, what happens that the blood vessels are going to dilate. So you have got no more amount of volume, but because the blood vessels have dilated, and then there is uh, just a problem with the distribution of the blood, like massive vasodilatation and the failure of the circulatory system to distribute blood properly. That is what leads to the total volume looking appearing low. But the volume really is okay. It's just that the vessels have dilated. For spinal cord injury, it's also a cause of neurologic, I mean distributive shock, which is a neurologic shock. It's not a common cause of hypovolemia itself. But if we think of it in terms of the what is going to cause the injury to the spinal cord in children, maybe it can be trauma, and that trauma is what is leading to the loss of blood or fluid. So it could be the problem. Otherwise, septicemia and spinal cord injury both are falling in the same type of shock. Yeah.
I haven't got more different.
For which one?
I'm not doing
Okay, why doc?
because I want to talk about the bacteria and pineapple. They are both problems of distributive, distributive shock. Distributive shock, right?
Yes.
Yeah, but for swimming, and even better is it it cannot cause a distributive shock. It can also cause a very shock. If it's september severe, well, it's indicated by causing inflammation of the bacteria leaves, leading to supply to the immunity, which might lead to food loss. But in spinal cord injury, by no means the root cause of the wound.
Yeah, that is true. In sepsis, the infection can lead to inflammation, and that will increase the capillary permeability, and that will lead to hypovolemia. The only thought I was thinking of for the spinal cord is when the injury itself is happening, maybe the trauma is because of, I mean, the injury is because of trauma that leads to blood loss. Otherwise, we can have spinal cord injury minus blood loss in trauma. But in septicemia, when you have got sepsis, this inflammation can make the vessels leaky, and that will lead to hypovolemia. Mm. So E can be an answer, a good answer, a better answer. Yeah, I also agree, because we can have spinal injury minus really this loss of fluid or loss of blood, but in sepsis, just the infection itself can lead to the capillary becoming leaky, that is going to lead to hypovolemia, besides the vasodilation itself.